Hello, good evening, and welcome to our bariatrics webinar. Tonight we're being hosted by the Inspira Health Spirit of Women program. My name is Laurie Trungone, and I'm the Assistant Vice President for Women and Children here at Inspira Health. And I'd like to thank all of you for joining us tonight. To our returning guests, welcome back. For our first-time guests, welcome, and we hope you have a great experience tonight. And to everyone, I hope you learn a lot tonight in a fun way that we like to showcase through the Spirit of Women program. So before we get started, I'd like to touch on some reminders about the Zoom format. The event should last about an hour, and out of respect for your time, we'll try to stay on time. We can't see or hear you. So the only audio and video that's turned on right now is for the panelists so that you can hear us. As we begin, you'll see some slides appear on your screen, and there's also a section for questions. The box at the bottom of your screen is labeled Q&A. Feel free to submit any questions that you might have throughout the presentation, and we'll address as many as possible as we can at the end. Your questions are only visible to our panelists. If you'd like to keep your identity anonymous, feel free to do that. You can check a box that says anonymous before submitting your question, and then we'll answer the question. We just won't know who it came from. But we want you to feel comfortable asking any questions that you might have. The purpose of tonight is for information, so that if anything comes to mind, please feel free to ask us. We'll also have questions throughout the presentations that will pop up called poll questions. These are usually yes, no, true, false, or multiple choice questions. And we encourage you to participate. It's just a little fun in between. It's part of our plan to make this a fun event. So tonight's program we entitled Gain Back Your Life, and really want to focus on some of the issues that we have as a society as a whole. Most of the, or many of the adults in the United States are considered obese. Although lots of people can make changes in their life and conquer obesity on their own, there are many of us who need some extra help. So tonight we intend to assist you in learning about the options for bariatric surgery and provide you with the logistics of, as well as the nutritional information that will help you reach your weight loss goals. And to bring us up to speed on what all this means, we have a panel of experts to help us wade through this information tonight. So first, I'd like to introduce Dr. Keith Kreitz. He is a bariatric surgeon and the medical director of our bariatric surgery program at Inspira Medical Center, and he's located in Millica Hill. He's an experienced bariatric surgeon dedicated to serving the individuals and communities of South Jersey as part of our Inspira Medical Group of physicians, surgeons, and providers. He completed his medical school training at Hahnemann University School of Medicine in Philadelphia, Pennsylvania. He completed his internship and residency at Lehigh Valley Hospital in Pennsylvania as well. And he served as the director of bariatric surgery at St. Mary's Medical Center in Langhorne, PA, before joining us here at Inspira. He specializes in laparoscopic weight loss procedures as well as revisional surgery. He's board certified by the American Board of Surgery and serves as a member of the American Society for Metabolic and Bariatric Surgery. He's also served as assistant clinical professor of surgery at both Louisiana State University and the University of Pennsylvania. So thank you very much, Dr. Kreitz, for joining us.
Thank you, Lori.
And secondly, we have Roseanne Ricano. She is the clinical outcomes manager for Inspira Medical Center in Millica Hill's step-down unit, as well as the bariatrics coordinator. She's nationally certified as both a bariatric nurse as well as a med-surg nurse. She has a bachelor's of science in nursing and a master's of science in nursing, and she also has a doctorate of philosophy in nursing. She's been practicing for over 30 years as an RN and has been with Inspira in our various hospitals for over 30 years. Recently, she was the primary investigator in 2 research studies focused on lifestyle alterations in postoperative bariatric patients and the impact of technology on the engagement of post-op bariatric patients. Thank you, Roseanne, for joining us tonight as well.
Thank you.
And thirdly, we have Brady Rojas. She is a returning panelist for our Spirit of Women program, and she received her bachelor's degree in nutrition from LaSalle University, and she also has a master's of science degree in health education. She's a registered dietitian and has a passion for teaching individuals how to live a happy, healthy lifestyle. She works in both the inpatient and the outpatient settings for Inspira Medical Center in Malachi Health. Thank you, Brady, for being a returning guest for us and joining us tonight. So we are in a crazy time with this COVID pandemic. We're all functioning very differently. We're doing a webinar instead of an in-person learning experience. We're finding this to be fun and educational as well. So I need to ask each of you, what is the first thing you're going to do when all this is over? Dr. Kreitz?
I suspect I'm going to have to take care of my kids. You mean tonight or the pandemic?
The pandemic, the pandemic. Roseanne, what are you planning?
Oh, we're planning a vacation, of course.
Good for you. Good for you. Where are you going? Anywhere good?
We're going to start off in Annapolis, but who knows where we'll end up.
Good.
Exciting.
And Brady, have any plans?
I keep getting emails. We're starting with travel little league, so I'll be at baseball games, I guess.
There you go.
Yeah.
Okay. Well, that's fun.
Mm-hmm.
Can you see my screen?
We see you.
Okay. I am trying to share my screen. I don't see the button to do that.
This is the part where you have to do an interpretive dance.
Yes, I'm sorry. Okay, here we go. Woo. I don't know what happened there. Okay, here we go.
Hey.
And we'll do this one. Okay. Whew, sorry about that. So let's get started. First, be proud that you're all here. You've already taken a step in the right direction. And we're going to start this program with a poll question. Approximately 70% of adults are considered overweight or obese. You think that's true or false? Okay. So that's actually true. So good that 86% of you knew that answer, which, you know, when you think about it, 70% is an awful lot of people. So you would think that it wouldn't be such a high number, but it is. Children aged 2 to 19 actually make up 17% of those who are obese. And just over 6% of adults are actually considered extremely obese. And extremely obese is a BMI over greater than or equal to 40. And we'll explain what BMI means a little bit more in this program. The medical costs associated with being obese are extremely high. Last year alone, there was $147 billion spent on the related health and medical issues that are associated with obesity. And approximately 112,000 obesity-related deaths occur annually, which is an awful lot, right? So, Dr. Kreitz, can you start us off with what obesity even means and what effect that really has on our bodies?
Sure, and I want to say thank you for having me here tonight, Lori, and welcome to all the guests who are here for the session tonight. Obesity is something that's near and dear to my heart because, as you can see from the screen, it's a disease in which fat has accumulated to the extent in which health is impaired. And that's really what we're trying to target. We're trying to target the health impacts of obesity here. This is not a cosmetic issue, like unfortunately so often it's played out in the media or in personal interactions, but it's something that really impacts people on many levels. So we definitely know at this point it's multifactorial. It really progresses as you get older, so it's lifelong. And a lot of my patients will come in and they'll say it really started in even grade school a lot of times. Mm-hmm. So when I meet someone who has obesity and I'm taking their history, I definitely see that progression, and they will tell me how their life has changed as it's gone along with that. And of course, as you kind of pointed out, there are a lot of costs that go with it, and it really impacts the medical system. And that's a big thing to try to turn around too, aside from making a person's life better. So you can see on this slide here, obesity is tied into many processes. It's not just a environmental or behavioral thing, as a lot of times we think about where a person eats too much and such. But really, we know it's strongly, strongly genetic. It runs in families. I talk to patients and they will definitely be able to point out, oh yeah, all my family's heavy, or definitely it's something that's come down through my family. But what we found out from our knowledge of how the genome is expressed these days is that it is the second strongest genetic characteristic after your height. And that's pretty dramatic. So your body's kind of locked into the weight that it wants to put you at. Now, environment plays a big part in it. There are certain indigenous peoples who just do not have the same processing capability for calories, and in certain Western environments, they get really sick, and it really is pronounced with them. And of course, there's a psychological part of it where we do have to watch what we eat. We have to be healthy. We have to kind of be active. And the part is the mindset with that. And sometimes, unfortunately, our emotionality plays into that. Everybody, I think, can relate to eating when you're sad, or eating in a crowd when you're happy and it's kind of like a social event, those kind of things. So there's so many parts that play into this.
And then how about what it does to our bodies?
Oh, that's a great question. So this is a very busy slide. So I apologize, everybody trying to read the small little print. Hopefully it's not too small there. But the big points of this are, it affects you from head to toe. And if you look at the diagrams here, a couple ones I'll really draw your attention to, the big three I call them: high blood pressure, diabetes, and sleep apnea. Those ones kill people outright. And it is a distressing fact. And most people don't realize how they're linked together because they're tied into heart attacks and strokes and things like that. But almost every organ system is impacted by obesity. Now, there's a journal that our society kind of sends out. I was just kind of perusing through. It's called the Sword Journal. And they were even talking about cancer in this one. And they're putting out a consensus statement of how obesity plays into cancer health. And you can kind of even see from this slide here, it is strongly linked to such common cancers as breast, prostate, colon. Those are pretty prevalent cancers, and they're definitely impacted by a person's weight.
Wow. Brady, can you tell us about the obesity crisis from a dietitian's point of view?
Sure. As Dr. Kreitz has mentioned, there is a genetic component of obesity, but one other factor is our environment. So good nutrition really plays a role in helping to combat this obesity crisis. And it's essential throughout our lifestyle. Unfortunately, it's not just for adults. We're seeing many young children becoming overweight or obese and having some of these chronic conditions earlier in life. So we're really trying to help prevent that from happening. Just some statistics to realize is fewer than 1 in 10 adults and adolescents eat enough fruits and vegetables. 9 in 10 Americans aged 2 or older consume more than is recommended for sodium levels. And then we can see the other statistic there about sugary beverages. And we know as health educators that added sugar, added salt, saturated fat, these are really the keys to empty calories that lead us to this obesity crisis. It goes further than just nutrition education. We need policies in place to help get access to these healthy foods in our neighborhoods and in every aspect of society. So I think there's a quote about 60 million children each day are in daycare or school. And sometimes that's really the only healthy meals they get. So we want to make sure that we're really focusing on healthy nutrition throughout their lifestyle.
Okay, so let's ask another poll question. Normal body mass index, or the BMI that I referred to before, and again, we'll explain it, is 25 to 30.9%, 10 to 15.5%, or 18 to 24.9. We'll give everybody a minute to respond. Looks like we have an extremely educated audience. That's great. So 90% think it's between 18.5 and 24.9. So Brady, can you tell us what normal is?
Sure. So let's start with what BMI is. BMI is better known as body mass index, and it's a really a calculation that measures our body fat based on our height and our weight. It's a general measurement, and it's one we can give to both men and women. You can see there that normal is 18.5 to 24.9. To be classified as overweight, you have a BMI of 25 to 29.9. And then there are 3 classes of obesity. Class 1 being not as severe, and then class 3, of course, being severe with many comorbidities. Obesity class 1, 30 to 34.9. Obesity class 2 would be 35.0 to 39.9, and then above 40 is that extreme obese class.
So Dr. Kreitz, can you show us how high BMI can actually decrease the length of time that we actually live?
Yeah, that's a pretty sad fact that you're leading us to with that question, where we definitely know that our weight is tied into years of life that we lose. And really, once you reach those higher levels of BMI, really, you can see on this chart here, getting up 35 and above, we're starting to shear 3 to 7 years off. And this chart keeps going. That's the sad thing, is that this only goes to a BMI of 45. And it is not uncommon for me to see patients with BMIs of 50, 55, 60. And those people are losing a decade or more of their life. And we're seeing people in their early 20s with diabetes and diseases that really shouldn't get for several decades later at the earliest.
Yeah. So Roseanne, we obviously know then that we need to lose weight. Can you tell us what some of the benefits of actually having weight loss would be?
Sure, I'd be happy to. So like Dr. Kreitz said, diabetes and high blood pressure, there are many life-changing benefits to weight loss, and specifically those 2 comorbidities are extremely affected by weight loss and have higher resolutions. You can see that on the type 2 diabetes, that there can be up to a 68% resolution. And if you were on insulin, you may be able to get down to pills, or if you were on diabetic pills, you may be able to just control diabetes with diet. So there are great benefits to weight loss, specifically for those 2 diseases. Obstructive sleep apnea, something that many patients are affected by. Great resolutions there, up to 76%. So losing weight really helps to improve our overall health. It helps us to improve our eating habits, really improving longevity and improving our quality of life. So lots of life-changing benefits of weight loss.
So if somebody then did want to get into the program to make some of these life-changing alterations, which clearly have lifelong benefits and longer life benefits, what would they need to do to prepare?
So a little bit about our program requirements. Our goals are in alignment with the American Society for Metabolic and Bariatric Surgery, better known as the ASMBS. It is the premier organization in the specialty of obesity and weight loss surgery. They have a wonderful website with a patient portal. You can reach that at asmbs.org. We have it up on the screen for you. Definitely utilize that as a great resource. They are also a wonderful advocate for our patients, and it really assists all of us in the healthcare profession to increase societal awareness about the disease of obesity, because we do remember that it is a disease.
Mm-hmm.
As far as preoperative preparation, one of the most important things is that there definitely is long-term follow-up with your bariatric surgeon. It's not just you have the surgery and you see the surgeon a couple of times. It's definitely not that. You develop a relationship with your surgeon, with your bariatric coordinator. We want you to have a long-term follow-up. We want to follow you for the rest of your life. We're here to support you. Education, one of the biggest and most important things that we can do for you. We help you with support groups and education sessions. Our education sessions are going on now via Microsoft Teams. And our online sessions, you can reach them by calling the 1-800-INSPIRA number, and someone from our colleagues in the Access Center will help you with that. Support groups are available as well, and they are free. So if you're interested in a support group, our contact information will be at the end of the presentation. Please feel free to reach out. As far as nutritional consultation, registered dietitians that are specializing in bariatric care are here available for you. That is a great preparation. We want to prepare you in the time ahead of surgery so that your transition to your lifestyle after surgery has a smoother transition to that. Psychological evaluation. All of our patients are required to see either a psychologist or a psychiatrist. And that is really a great way to see how you will cope with these lifestyle changes for after surgery. Of course, incorporating healthy eating and exercising in your preparation is a wonderful way to transition. And different insurance companies do have different requirements, and we'll talk about that a little bit later in the presentation.
So Brady, Roseanne mentioned the nutrition counseling session prior to the surgery. So can you tell us what's involved with that?
Sure. There's usually multiple nutrition sessions prior to your surgery. I would say at least 2, but it could be as many as 6, depending on your insurance. And it's really a good time to start having a conversation with the dietitian. You will be asked information on your health history, your weight history, your current eating and other lifestyle factors. You can expect that your height and your weight will be measured at every visit. It's all done privately, so you don't have to feel like you're out in the open. We just might ask you to take off your shoes, depending on what kind of shoes you're wearing. And then, just to expect to be there, it's not a quick visit. We're really trying to understand your lifestyle so we can help you make changes. So the first and second appointments are typically, I would say, an hour, and then the follow-ups thereafter are a little bit quicker. Okay. What else you can expect? We're going to have a discussion with you. We will never pressure you into following anything that you didn't want to follow. Our goal is to help you make changes that are realistic and sustainable in your lifestyle. It's not going to work well if we tell you what to do and you're not in it with us. We also take into account your medical conditions, your cultural or personal dietary requirements. I understand that everyone doesn't eat the same things that I like to eat, and I might not like what you like to eat. So we really take a good pride in recognizing your likes and dislikes. We do recommend that you keep a food journal. We have a little mantra, like if you bite it, write it. So even if you just walk through the kitchen and grab a few grapes, we want to make sure that you're accounting for everything that you're eating and drinking throughout the day. That is actually something that you can start even leading up to your nutrition counseling sessions. So feel free to take out your journal or go online and find an app that you can start journaling your food intake. Another thing that you can do now is really start to focus on your meal plan. If you started a food journal, kind of look back. Are you eating 3 meals a day consistently? If not, maybe make that one of your goals, to start eating meals at a scheduled time or consistently throughout the day. Meal prepping can be as little or as much as you want to put into it. Sometimes all those little containers of everyone's planned meals, that overwhelms me a bit, but I like to make a menu and at least shop for based on that menu. So meal planning can really be, again, a wide range of preparation ideas that we can help you determine in our session. And I can't stress this enough, the time is now to start moving. So it's, summertime, I know it's a little hot, but get up, go for a walk. If you're able to do any other activities, we just want you to get moving, because physical activity goes hand in hand with changing your nutrition intake as well.
That's great. So to our audience, if you put your cursor at the bottom of your screen, you'll see a hand that you can raise. I'd like for you to raise your hand if you or someone you know has had bariatric surgery. Okay. We'll give everybody a minute to raise their hand. Wow, that's about half of you either know or have had bariatric surgery yourself. So that's actually really good. It makes it a little less overwhelming if you know somebody who has had this type of surgery. So Dr. Kreitz, how do we know if we're a candidate for surgery?
Well, there's some guidelines that were put out by the National Institute of Health, and you can see the first one up there is the BMI guideline. Back in 1991, they looked at all the data that had been accumulated up to that point and realized we've been doing bariatric surgery since the 1950s at least. The procedures have evolved, changed for the better, but we've certainly learned a lot about how the outcomes are and who benefits the most. And what they saw even in 1991 was that if you have a body mass index of 35 and above, and you have those comorbid illnesses that we saw on the earlier slide, those ones that go along with obesity, then the NIH actually recommends you have weight loss surgery. Now, if you don't have those illnesses, the BMI level goes up a little bit to 40. So you could be a perfectly healthy, otherwise normal person, but if your body mass index is 40 and above, we know that the impacts on your life are going to be so significant, life loss, future illnesses, that they also recommend you have surgery at this point too. Now, other things are important. You should be healthy enough to have an operation. That goes without saying whenever you have a general anesthesia type procedure. Everybody should have tried at least to try to lose weight without surgery. Surgery is great, but we know a small subsegment of people are able to get the weight off and keep it off at least for a while without surgery. So I want them to have made that attempt. But we also know that people who have tried to lose weight before surgery make better surgical weight loss patients in general. It's the same teaching. We're not doing anything different. Brady's given similar counseling to my surgery patients to the ones that never go to surgery because it's really the same science behind it. Other things that go in there, obviously, we don't want to have any drug or alcohol abuse that's going on because that's a confounding factor that's going to make you not successful with these type of procedures. And again, if there are other psychologic issues that are active or in play, they need to be really under good control and really being treated to the point that it's not going to impact your life and you can follow these healthier guidelines. Now, that all comes together through a multidisciplinary team kind of evaluating the patients. Roseanne talked a little bit about that. You see the behavioral health doctor. You'll get tested for sleep apnea. You'll see a cardiologist. Of course, you see Brady a whole lot, and she's kind of putting a lot of input in there because she's really watching how you're progressing with your lifestyle changes. And that comes together about making that good, hard decision that supports surgery then. So, and probably the most important thing, the patient has to understand the procedure. Our main goal is to educate the patients, and we have several classes for that. Roseanne puts on great sessions teaching. Any way that the rest of us can roll into that and help educate the patients, we try to do. But we want the patients to know the tool we're giving them because that's really what it is. As much as it's a lifestyle change and a strong commitment, it's also a tool. And without the proper effort behind the tool, we're not going to see the results we want to get.
So what are the surgical approaches then?
Okay, so the great thing is we live in a day and age where now we have choices, right? Life is so many choices. Sometimes it's a little crazy, right? Yeah. There are a few top candidates that are kind of the nationally recognized ones. Now, there are other surgeries that are doing investigational, but these are the ones that we offer here at Inspira in Mulligan Hill where I'm at. And these are actually the most popular ones anyway, because nationally we can kind of guess and we kind of know from data sets of how much is really going on. Now, the oldest one you see on the list here, the top one, is the Roux-en-Y gastric bypass. That one was what we used to call the gold standard for years and years. And it's a really, really good operation. It's been around since 1967. It's been done laparoscopically since 1996. There is so much data on this procedure that we understand it really well, and it's a really safe procedure. Second one, sleeve gastrectomy you see on that list. That's a procedure that's actually been around for a while as part of another procedure, and then was so useful, effective, that they actually broke it off and made it its own standalone procedure around 2010. And why I say 2010 is because that's when Medicare started approving patients they can have it. And really once Medicare has looked at the data and they approve a procedure and they give it a code, it really becomes dogma at that point and it's accepted. Now, the third one on the list is the lap band or lap adjustable gastric band, or just the band for short. Now, this procedure came out in the United States around 2001. Now, it was in Sweden before that, called the Swedish band, but it got approved by the FDA in 2001 and became very popular because it was a less invasive alternative to the gastric bypass, which was the only other procedure at that time. Now, the lap band enjoyed popularity for about 10 years, but then started to fall off because the other procedures really eclipsed it in their effectiveness and their durability and really their ease on the patients to really kind of have a good lifestyle and not really have issues to deal with later on. And then the last one on the list is one of the nice ones we're going to talk about here today, which is called endoscopic gastric balloon placement. It's part of a new field we call endobariatrics. And these are procedures we do without general anesthesia. These are procedures that we do with small little tubes going down through the throat, or things patients swallow, or different things like that. And they do not leave scars in the body or things like that for the most part. So it's a brand new field. We are gathering data on this. It's now been around since 2015. Patients are coming to appreciate having an extra modality available rather than one of the other surgeries if they're not able or not ready to commit to it. And the other thing is insurances usually cover all these nowadays, which is a great thing, but we didn't always have that. But gastric balloon placement also gives us the ability to treat patients who don't have the insurance benefit too, which is nice.
Okay, so let's ask the audience a question. So everyone knows Al Roker, who is a weather forecaster. He was overweight, certainly, and he had some procedure. I'd like to know if you know, oh, look at everybody already answered.
They like that question.
Finish the question. Okay, so we do have some other people. So did he have the Roux-en-Y? Did he have the vertical sleeve, the adjustable band, or the gastric balloon placement? So 67% of people think he had the Roux-en-Y, and another 33% thought maybe it was the sleeve. So can you tell us what Al Roker had?
Okay, so Al Roker had the great and famous Roux-en-Y gastric bypass, or laparoscopic Roux-en-Y gastric bypass, or just the bypass, as people say it. So this is a nice procedure. As you can see from the diagram there, there's a lot going on. But if you break it down into a couple little phases, if you look at the top of the little picture, you can see there's a small red arrow that's going into the stomach there. That small red arrow is pointing to what we call the pouch. What we do is we actually divide the stomach and make a small front pouch about the size of a golf ball. If you cup the golf ball in your hand, that's about the volume of the small front pouch. And what that does, that serves as your initial food reservoir, that when you swallow something, it goes into the pouch, fills the pouch, gives a little stretch. Small amounts make you feel very full. That's called early satiety. So patients will eat smaller amounts. They'll sometimes say 2 or 3 bitefuls, I feel really full. And that's a good thing because they're satisfied with what they ate. It curbs their hunger with small amounts. Now, the second part of this, and this is a combination operation. I hate the term. They use the term malabsorptive, but anything that has mal, I don't like. What I like to think of is just think of it as the bypass kind of way, where basically we have to have the food exiting the pouch. So now, right below that red arrow, you'll see a little piece of piping, which is intestine, that's been hooked to the pouch. Now, that piece of intestine used to live much further down at the very bottom of the screen, but the surgeons went in there and cut the intestine and pulled it up to create a faster pathway for food to go through from the pouch to the lower intestine. That works out well for a couple reasons. One, it bypasses the stomach and the first portion of the small intestine where early digestion happens. The other part of that is those first areas of the digestive tract are where the digestive juices pour in to the intestines and the stomach, and they mix with the food and help to start releasing the calories and such. Now, when food goes through the bypass loop, it doesn't mix with those digestive juices till much lower down, so you have less breakdown of the food, less absorption, and less calorie retention from what you eat. So you eat less and you absorb less of those calories, which is very useful. So great things. We're only working with native tissue, so there's no foreign devices in there. It's just I like to say it's like a carpentry or plumbing job, more or less. So nothing funny is left behind. We're just doing a little rerouting. Now, this is the operation that became popular after 2010, and actually, this is the most common one we're doing these days. I'm sorry. This is gastric. I'm sorry. I was thinking sleeve. We had a sleeve slide up there, I thought a second ago, right? This one here is gastric banding. This one is also a laparoscopic procedure. This is the one that came out in 2001 and then was around, and it's actually still approved. It's still FDA approved. And I say to people, if you can't have a sleeve or a bypass, I would still give you a band because the operation does work. People lose weight with this operation, not as much as with the gastric bypass, where you'll lose 50 to 80%, but you'll lose about 30 to 40% excess weight with the gastric band. And from the little picture here, you can see there's a little white band around the upper area of the stomach, kind of in that same area where the gastric bypass pouch is. And you kind of make a small pouch with the band by snugging up that area of the stomach. So when people eat, it goes into the front area of the stomach, gives a little stretch, just like with the gastric bypass, and then that gives that feeling of fullness. Now, the nuance with the gastric band is that that little ring that creates the pouch for the band is adjustable. it can be tightened or loosened. And the way it's tightened or loosened is with pneumatic pressure, kind of like the brakes on your car. So there's a little port, sits under your skin, usually on a person's abdomen, and we can actually give a little injection of salt water, saline, into the port. It goes through that little tube you see on the screen there, and it goes to the band and actually snugs the band up. And what that does is it makes the aperture, the opening of the band, get smaller. By getting smaller, it slows the passage of food from the front part of the stomach, that little pouch we made, to the lower stomach. So we not only eat less, but we have a slower passage of food. So great operation. It's pretty simple like that. It had some downsides where we're putting in a medical device, and no matter how great of a medical device, like I say to patients sometimes, you can buy the best tires in the world and drive around, and someday you got to have them replaced. You're going to have to go to the garage. Doesn't matter how great your tires are, they will not last forever. And the same thing with this. The band doesn't heal itself. So after a certain amount of time, it more or less, needs to have some work done to either repair it or keep it up to speed. And most people don't want to have a second operation or third operation, because once you have an operation, you kind of want to be done. As much as my patients, and I love each other, I tell them, you probably don't want to see me a whole lot. You want to see me on the street and wave to me and say, hey, I'm doing really good. Because if you see me in the office, that means we're doing something together, like surgery. And unless you're a glutton for surgery, you probably don't want to have too much of that. So we like to do it once right. This is a great operation, but the bypass and the sleeve kind of really left this, behind, because when we saw we had to do the maintenance work on these ones, it became less popular. So nowadays, it's about 1% of what we do.
And you're not crazy. I did skip the sleeve.
Oh, good. I was like, oh my God, was I seeing things?
No, you were right.
Okay, so this is the most common one, as I was saying. This is sleeve gastrectomy, or vertical sleeve gastrectomy. There was an earlier different one called a horizontal sleeve gastrectomy. That is not this. This is vertical sleeve gastrectomy. Or when we say nowadays laparoscopic sleeve gastrectomy, it's always vertical. So this is important because around 2010, this was broken off as its own standalone procedure. On the diagram, you can see there appears to be a little separation between one side of the stomach and the other side of the stomach. And the inner, what we call the lesser curvature, so the smaller area of the stomach that's left behind, is fashioned so it's kind of smaller in volume, and patients can kind of appreciate it. Kind of looks banana shaped. So they say, oh, I'm going to have that banana operation, right? So the idea is that we've created a smaller stomach, and then we take out the rest. The rest you don't need, we found out, because food passes through. It's not a bypass. We're not rerouting things. So patients love that. They're like, you're not going to reroute things, because I'm not sure I'm so happy about that. They like the fact that, as I say, they may pinch their side a little bit and say, I want to lose some of this. And then we say, okay, we'll pinch a little stomach, we'll lose some of this. And then they work together, which is very nice. Now this one has a duality, which is kind of interesting. So we decrease the volume of the stomach, so you can kind of understand, like we said before, smaller volume makes you feel full earlier when you eat a meal, which is great, so you eat less. But this is interesting because we're actually taking out some of the body of the stomach. And by reducing stomach size, by actually taking out the excess stomach, which is unique to this operation, we take out an area that secretes a hormone called ghrelin. And this was interesting. It took us years to really understand this. Ghrelin is a hormone that is released by your stomach when your stomach's empty. There are little stretch receptors that can tell when your stomach's being stretched and when it's flaccid. When your stomach's flaccid, it kind of knows there's nothing in there to distend it. So it releases a little hormone. Hormone goes up, goes to your brain, your hypothalamus, to your appetite center, turns it on. Makes you think about food, makes you hungry. That's when your stomach's growling. You can bet you're releasing ghrelin in your system. When you do a sleeve gastrectomy and you take out that excess area of the stomach, we see that hormonal level fall. And that hormonal level falling correlates with people just having less appetite in general. They are not hungry all the time, which is great, because a lot of patients are really hungry all the time and such. And that's, a tougher thing. You want to lose weight, but you're hungry all the time. It's a tough thing to fight. They come in, they say, Dr. Kreitz, I'm just not hungry. I said, the surgery worked. See, and patients are still surprised because they didn't expect. They're like, wow, it really does work. So that's a great thing about this. And I like to say, sometimes I make a little bit of a casual joke. If you've had your gallbladder out, or if you had your appendix out, I'm like, do you miss your gallbladder? Do you miss your appendix? People are like, oh God, no, that made me sick. I hate that organ. Same thing. You don't miss the excess stomach. You don't even really know it's gone. You're really like a gallbladder or an appendix patient later on. Yeah, you had a little bit of surgery, but your body's really normal. Everything's in continuity. And guess what? You lost weight and got healthier. That's a pretty good effect.
Very good. Are there, in general, are there risks to bariatric surgery?
Well, there definitely are risks to all surgeries or any surgery. And if anybody tells you otherwise, they're not telling you the truth. So each of them has their own particular risks that I like to point out. Now, we'll talk about in general bariatric surgery. Obviously, we're making little poke holes. We're doing little cuts and such like that. We're cutting and manipulating organs. Any of that can cause bleeding. It can cause an opening or a hole or leakage of things, because we're kind of doing plumbing. We're fastening things together. When you fasten things together, you got to have a good seal. But in the body, you can make a good seal and then the body still has to heal it up permanently. So there's a lot of variables with that. It took us a lot of time to really get that down as good as we got it, but it's a pretty polished art these days. Other things that go with it, people who lose a lot of weight, guess what? They can form gallstones because cholesterol is in your cells. And as your cells shrink and you lose the excess fatty tissue, it goes out through your liver. And especially in people who have a genetic predisposition to it, it can sediment out and you form these little stones. We have medications to try to prevent that these days, but it is something that everybody has to know about. And of course, people can get areas that narrow, or they can get ulcers with these operations. They can have some nausea and vomiting. You know, it is an adjustment. You eat small meals. And this is probably something, you know, Brady is probably such an expert at, is really telling people to chew their food slowly, appropriate size. It makes it so much easier. You know, that old thing, 32 teeth, chew one for each tooth, very important. And that's important with these kind of surgeries here too.
Okay. So what about options for people who either can't have general anesthesia or are afraid to have general anesthesia? Are there any options for them?
Well, luckily there are. And that was a tough thing, because there was a day where people would come to my office and their BMI was under 35, or even it was a 37 and they didn't have any medical problems. And thank God they did. Thank God they did. But they wanted to lose weight, or they knew they were going to have problems down the road, and there's nothing I could do about it, because really there was no options. Now things have changed since these endobariatric procedures came out. It's given us the ability to treat patients at any level of being from overweight to obese to severe obesity. And this one here you see on this page is the one that we offer here at Inspira. The first arrow, or the arrow you see in the middle, points to the single balloon. And it looks like an 8-ball from a pool table in there, but really it's not. It's a saline-filled balloon. And I don't know if they stole the technology from a breast surgeon and they took a breast implant and they put it in someone's stomach or something like that, but boy, it works great. So it is a saline-filled balloon that's put down through the throat with a little flexible tube with a camera on the end. And everybody's probably heard of Katie Couric. She got her colonoscopy on TV years and years ago, right? Everybody, you better have, because everybody needs to know about colonoscopy. So it's the same kind of thing. And I think Will Smith even had a colonoscopy and it was on TV and he was awake for it or something like that and such. So these things are becoming very popularized in the media and society. So conscious sedation, flexible tube down the throat, inflate the balloon, and the balloon sits in the stomach. This particular balloon stays in the stomach for 6 months. And what it does is it's a space occupying device. So it gives you a little feeling of fullness because your stomach's a little stretched. Remember that ghrelin response. It also kind of regulates the food passing it. So you can kind of see the balloons up against the walls of the stomach in this diagram. So the balloon kind of helps keep food in the upper part of the stomach to keep you feeling full. And it kind of takes longer for it to get around to the lower part of the stomach. So it kind of slows down the transit time. Now, what does that translate into? Translates into weight loss of about 35% in studies and 40% of excess weight loss in people in the real population. And this is the great thing I like to say, because there was a question at conference one time where they said, well, why do people lose more weight with this balloon off study? And the funny thing is because they pay for it. In the study, they got the balloon for free, and people probably didn't have to commit as much because everything was paid for. But when they actually had to pay out of pocket, like if you pay for your own college, you really study harder and you work harder, right?
Yeah, that's true. That's very true. Sorry, go ahead.
Another part to this here is the Brady part. And now this balloon stays in for 6 months and it has to come back out with a second endoscopic procedure. But these patients, you know, will come and see Brady and our nutrition team for 12 full consecutive months to really make this device and get the technology down and the eating habits to stick in place. And that's what we really see. You see that about 26 months, people still kept the weight off.
Oh, that's fabulous. So, you know, you talked about what the weight loss would look like with the balloon, but what about the other procedures? You know, what does it look like after, you know, the procedures in terms of what people can expect to lose?
Okay, so that is the first thing. A lot of times patients will say, well, what do you think I'll weigh at the end of my procedure? And really, it's a case-by-case basis. So if you had Hulk Hogan or you had grandmas, we'd say in my residency, they're going to have different bodies, right? So at any rate, the more you weigh at the beginning of the procedure, or any procedure, the more pounds you'll probably lose overall for the same person having the same procedure who's a smaller patient, right? But percentages will change. Now, in particular, gastric bypass, what I usually quote, most of the data falls between 50 and 80% of excess body weight loss. So what is excess body weight loss? Okay, so Brady was talking about, you know, BMI, and we had a little poll about where your BMI is. So if you find out what your ideal body weight is, that anything above that is considered excess weight. So if you are 100 pounds over your ideal body weight and you're going to lose 50%, you'll lose 50 pounds. Easy way to think about it. And that's with gastric bypass, 50 to 80% excess weight loss. Sleeve gastrectomy comes in a close second, somewhere about 50 to 70, almost 80% excess weight loss too. And we're starting to see the weight loss with sleeve patients on the longer studies starting to look like gastric bypass. So it always makes me feel better and better that it's a really close, you know, comparison between the two. So there was a feeling that people with gastric bypass lose the most, and I think that's still true, but it's so close, I don't think you can hang your hat on there's going to be that much of a realistic difference between the two. And then the next one was the lap band, and with that one, you'd lose about 30 to 40% of your excess body weight. So that's kind of comparable to the balloon, where you also lose that 35 to 40% excess body weight. So those are kind of like tier 2 procedures, I'd say, in my kind of like little lingo world, where you lose about a half or 2/3 as much as the more formalized stomach procedures.
So then how do you decide what procedure?
Okay, so that's a great one. So, well, first of all, I ask the patient that when they first come in the room. First time meeting, I shake their hand, or I guess now I bump elbows and anything like that, right? Before someone tried to shake my hand today, I had to pull it back. I was like, I'm not being rude. No, really. So with these procedures, people know. They've done a little research a lot of times. And you know, as our poll pointed out, half the people either know someone who's had it done, or they've had it done, or they've looked into it and they're thinking about it, like today's discussion really. So they come in and they may know the procedure they want. Then we kind of talk about if that's the right fit, or if there are other things that are important to kind of rethink that. Now, some procedures don't mix with certain medical problems or lifestyles. Like with a gastric bypass, a very effective procedure, but not good in smokers. People who smoke can make themselves very sick from, you know, a gastric bypass, because it makes you form ulcers if you have a gastric bypass. So that's not a good thing. And likewise, if you're an ulcer former in general, or you take certain medicines that make you prone to getting ulcers, they don't mix good with gastric bypass either. So someone who's on like a heavy dose of aspirin or anti-inflammatories for their back, probably not a good thing to give them a gastric bypass. But like I said, we have choices nowadays. Sleeve is a great operation where really it's one size fits most, I would say. Most people can get sleeve gastrectomy. The only people I'd say who may not want to get sleeve gastrectomy is someone who has really, really bad heartburn. They have a large hiatal hernia. They have heartburn so bad that they have pretty active regurgitation. And this is not a large amount of the population, so it's very few people and such, because you can get a little bit of heartburn after sleeve gastrectomy, but if you already have a whole lot of heartburn, it can make it just that much worse that you don't want to have it. So those are the big ones. Now, the other thing's insurance, but you know what? Really not much of a factor anymore because it's so widely covered. But like I said before, if you don't qualify by insurance means or NIH criteria, then that's where the balloon comes in. So the balloon allows us to treat those patients. So.
Okay. So Brady, then once the surgery is complete, what can people expect to eat?
Sure. This is my number one question. What can I have after surgery? There's many different stages, as you can see up on the screen, but it's not a long time. To be honest with you, about a month or maybe 6 weeks post-surgery, you're back to regular food, regular textures, maybe not the same foods you ate prior to surgery, but we'll be working with you on that. You're going to start with clear liquids, literally anything that you can see through, water, broth, or any calorie-free beverage. And then it generally progresses up to more solid food. I usually recommend or suggest that it's kind of like feeding a baby. You kind of start small, very light, thin liquids, and then you slowly incorporate the textures back into your diet. Your bariatric team will tell you when you're going to go to each stage of your diet and kind of help you walk through that process.
Okay, so Roseanne, can you help people with then what would be the next step?
Absolutely. We want to encourage our patients to set realistic expectations of their weight loss. And Brady alluded to it earlier about goal setting. So we work with our patients to help them formulate goals that are smart and attainable. remember, the bariatric surgery is a tool, and we certainly are a great support system for you. You'll have your family for support, but you also have us. We're a multidisciplinary team that provides wonderful support. We have free support groups. We encourage our patients to join us monthly. Remember, it's a team approach and we're here for you. So we want to congratulate you. This is really the first steps to make this commitment and to remember that surgery isn't the end of the journey. It's really the beginning. We're always there with you. We're walking with you, and we are here for you.
Very good. Thank you. So let's just ask another question. True or false? Insurance will cover my weight loss surgery.
Ooh, I like that one.
That was good. We've got a very educated crowd. I think they've already been to the webinar. Okay, so Roseanne, tell us.
We'll talk a little bit about insurance requirements, and basically they really do depend on your policy. So most insurances will require our patients to have a BMI of greater than 40 or greater than 35 with significant comorbidities such as the hypertension and the diabetes that we spoke of earlier. As Dr. Kreitz mentioned, the documented history of weight loss attempts in the months prior to surgery. Specific evaluations by the psychiatrist and psychologist, cardiac, sleep medicine evaluation. Insurances require these as well as our program, and as well the nutritional counseling. So we want you to know we're here for you. We're going to help you verify your benefits to ensure coverage, reviewing your specific insurance plan's coverage with you. That's done at the first visit in the office, and the office will help with submitting the specific documentation you need for approval for surgery. So, you know, it's active patient involvement too. So like I said earlier, please be a good consumer and reach out to your insurance companies as well.
Great. So we do have some time left for some questions and answers. So let's start. We do have a number of questions, which is great. So Dr. Kreitz, do you find that most patients need to have extra skin removed after weight loss surgery?
Ooh, that's the most common one I get asked for
I'm
the
sure.
FAQ question when I do these talks. Here's the great thing. 95% of people don't. Now, it all depends on where you start from. I'm going to be honest. If you're younger, more likely you have good elasticity in your skin. If you are a non-smoker, usually have better elasticity in your skin. If you were a sun worshiper and you did a lot of sun tanning, not as good for your skin. And it also starts on how much weight you're going to lose. So if we have people who are going to lose really, and I've had patients in the 600-pound range. And again, if they're going to get down to the 200-pound range or something like that, that's going to be a much more dramatic change than if I get someone who's like, say, 240 and then they drop down to 170, which is probably the majority. More people are on the smaller end of the scale because that's just how humans are and stuff. So thankfully, most people don't have a problem. But I tell everybody, wait the full 2 years. Let's get you to your baseline level where your weight's nice and stable. And then we evaluate and give your body a little time to catch up. Because just like after a woman has a baby or something like that, you know, the moment she drops the baby, she's not back to normal. Her body needs time to catch up with it. And that's what happens. As you lose the weight, you let things see if they can shrink down. You try to work on your, you know, muscle mass and try to get your exercise in to do as much toning to kind of preserve that. That can help out too. So there are a lot of factors, but most people don't have to. Now, don't tell the plastic surgeons that because they want me to send everybody to them.
I'm sure. So Brady, one of the other questions is, what is your stance on dietary supplements for weight loss? Are they safe, or how do you feel about them?
Sure. You know, there's definitely a time and place for prescription medications for weight loss. There are some FDA approved oral medications that you can take. I kind of worry a little bit about over-the-counter medications. You're not sure that you're truly knowing what's in them. I don't want to say that they don't work, but there's always that disclaimer, diet, you know, will work with diet and exercise. So let's focus on the diet and exercise part of it. That's my stance, at least, just to make sure that you're really focusing on your lifestyle changes. If there was a magical pill, I don't think we would be here having this discussion. So keep that in mind.
And if you find it, could you let me know?
Sure.
So Roseanne, with all the required protocols and insurance, verification, approvals, all that stuff. What's about the average turnaround time that leads up to surgery?
So typically the average preparation time may be in the 3 to 4 months preparation. It really depends on how engaged our patients are and if they are getting their testing timely, getting their educational sessions completed, but also remembering that they have the bariatric coordinator, myself, to reach out to help facilitate some of that. We work very closely between within our office and within the other offices to help get patients to surgery in a timely manner.
Okay, that's great. So Dr. Kreitz, one of the questions is, after people have had weight loss surgery, some people gain it back, some people keep it off. About what percentage of people actually are successfully keeping the weight off?
Okay, this is a good one. We have studies that even go out as far as 10 and 14 years. There's a little town in Connecticut called Framingham, and what they did was they made everybody go into the medical register rolls, and it's a wealth of information. And guess what? Over the years, a lot of those people had bariatric surgery. So we're able to look at people going through decades of their lives after bariatric surgery, especially because it's hard to do a study at a hospital because the residents graduate or maybe the team leaves or something like that. But Framingham, you had a whole community. What we know from gastric bypass is that the 10 and 14-year data show that there's about an 80% durability to it, which is really good. Mm-hmm. Now, sleeve gastrectomy, remember I told you that came out as its own surgery around 2010? Right. We have about 8 and 10-year studies, and they're starting to show about the same durability as gastric bypass. And interesting, people seem to even lose a little bit more weight somewhere years down the road, which is different. I see that, and I don't know if the data supports that, but I see a little trend. So both those two operations have really good long-term data sets. And that's even better than open heart surgery, because if you have the best open heart surgery, if they take what's called your left anterior descending and they stick your left internal mammary artery to it to re-plug in blood vessels, only lasts about 7 years. So bariatric surgery, longer duration than open heart surgery. And everybody goes for open heart surgery if they have a heart attack and they need it. That's without question. So.
Right. Is it true that you can't drink, I guess, Brady, this one would be for you. Is it true that you can't drink beer and soda after the surgery?
It is physically possible to still drink beer and soda after the surgery, but that's just not something that we recommend. Definitely the soda, it's really empty calories, high in sugar. The carbonation is something that we want you to avoid after surgery, especially immediately post-op, because it is a gastric irritant. It could lead to, some discomfort for you. As far as the alcohol question is concerned, I do have patients that are post-op, not immediately, but maybe a year or so out, and they might drink alcohol, but you have to remember your body is absorbing your food and your drinks much differently. So you can't go back to your normal, Friday night partying. You really have to be careful. And again, really, we want you to learn how to live a healthy lifestyle and not have a lot of these empty calories that you can get from these beverages.
Okay, thank you. Roseanne, do you have a whole team that helps to schedule all of the required appointments?
We do. We're an interdisciplinary team. So we work with the office and the hospital. Great teamwork in our office. Also in the hospital, we have cardiopulmonary therapists and our registered dietitians and people in imaging and all of our nursing departments working with each other so that we could get our patients to surgery timely and help them in their recovery. It's really is a team approach, and we stand by that, and it does show success.
Great. I think we have time for a couple more. We do have a number of other questions. Dr. Kreitz, question is, if I already had surgery in 2014 and it didn't work, can I do it again?
Depends. Depends on what happened. Depends on what the status is of the surgery. Now, what I say to a lot of patients, if you had complications, something may have changed on the inside that needs to be adjusted. That's the first thing I kind of look for. Second thing is I usually say the 4 fundamental questions. 1, are we doing our exercise? Really, really fundamental. That's probably the easiest one to say yes or no to, because everybody knows the exercise that didn't. Number 2, is your eating still healthy? The things that Brady teaches to the patients, because no matter what surgery we gave you, if I gave you a surgery yesterday or 10, 15 years ago, if we don't exercise and don't eat healthy, we're not going to keep the weight off like we're supposed to. And then another third one, are you seeing Roseanne for support group? Support group's really fundamental, and our support group, like any support group, has been shown to give you better durability of keeping your weight off. And last but not least, when's the last time you saw your surgeon for bariatric surgery? These surgeries, like your car, you take your car in every now and then for maintenance and anything like that. And I'm not saying we have to change the brakes or anything for that, but you got to come in at least for a little checkup and make sure we're keeping you on the rails and things are doing right. If those things are all no's and we're not keeping up with that, I hate to say, any surgery we give you is not going to have the desired result where we want to get. We got to really have that lifestyle incorporated in with it. So there are mechanical things we can reoperate on, so yes, but there are also things that we got to keep in the lifestyle that's probably even just as important.
Okay. There are a couple of questions around the support group. So Roseanne, I'm assuming these would be for you. Are they virtual? Are they Facebook Live? How are you doing the support groups? I know you're in Mullica Hill. That's one of the questions. But when and where and how are you doing the support groups?
Sure. So right now our support groups are through Microsoft Teams. And if you're interested in joining us, our support groups are on the second Wednesday of the month. I apologize. We just had one last night actually, and we had we had a nice turnout, a couple of new patients, some returning post-operative patients, but we meet for about an hour, and right now we're meeting on Microsoft Teams. Of course, when we get back to our new normal, our goal is to meet face-to-face, and it'll be the same night, the second Wednesday, and it'll be here in Mullica Hill. And
Okay.
Please reach out to me if you're interested in joining. For the Microsoft Teams, I really need to set it up with an email, but please feel free to reach out to me.
So, and I didn't mention, but everybody's contact information is on this slide. So, and for those of you who don't know, Microsoft Teams is a kind of similar platform as to what we're doing tonight. Right, where you can see each other, you can have a dialogue, you can not see each other if that's what you choose, and you want to kind of be anonymous. That's fine too. Two more questions, if we could get to two more. One of them is, I only have Medicare. Does that cover the surgery?
Well, I'll tell you, we love Medicare because Medicare actually is one of the most interesting ones where Medicare has some guidelines, but they don't actually pre-cert people for surgery. They basically say, yeah, as long as you make a good case, they can go ahead and have it nowadays.
Oh, that's great. Is there a requirement for losing a specific amount of weight beforehand, whether that's a percentage, or how does that work if you have to at all?
That's a little tied into your last question there, where there's no hard requirement that's out there. Now, some programs will make you lose a certain amount of weight, and the data does show that a patient who can lose some weight before surgery will be better surgical weight loss patient afterwards. But then we'd leave everybody out in the cold who couldn't get the weight off, and that's the whole reason they're seeing us in the first place, to tell you the truth. But the second thing is, some insurances do have benchmarks that you have to show some weight loss before they'll approve you for the benefit. I know when I was in practice in Pennsylvania, some programs or some policies would say you have to lose at least 3% of your excess weight before they'll approve you. So I'd say, look at your policy closely. Look at the verbiage to see what they say. That's going to be a strong determinant, because those records and those weights that we take in my office, we have to send them off to the insurance company to get approval.
Okay, thank you. And thank you very much, Dr. Kreitz, Roseanne, Brady, for taking this time to educate us tonight. To our attendees, thank you all for joining us. The presentation from my perspective was very informative. And then to the people who attended tonight, you will get a recording of the webinar in case you want to go back and listen to something again. Dr. Kreitz is available through our Inspira Medical Group practice in Mullica Hill. Obviously, he's taking appointments both in person and telemedicine, if that's something that you're interested in doing. I'd also like to thank our marketing team, who does all the background work for putting these programs together. Suzanne Bauer and Lauren Clinton, invaluable to us. In the meantime, wear your masks, wash your hands, keep 6 feet social distancing, because we're not done. So keep top of mind to stay safe. And thank you again for joining us tonight. And we'll see you soon. You'll get some information on our next programs. So thanks again to everybody.
Bye.
Bye-bye.